So let's begin the discussion of gynae with a very important and basic topic, menstrual cycle. Right now in gynae, if you've understood menstrual cycle and hormones, that is one thing which you have to understand, because if you understand menstrual cycle and hormones, you can answer questions on PCOD. PCOD is related to it, menopause, then endometriosis, fibroid, right? The other thing which you have to understand in gynae is anatomy. Now, if you've understood anatomy, that solves your questions on prolapse, right? Then you have to understand the next thing which you have to understand in gynae is embryology. To the embryology is related puberty, and if you've understood embryology well and puberty well, then you can understand amenorrhea well, right? And the last thing which you have to study in gynae is the cancers, right? So menstrual cycle and the hormones, they form the basis of gynae. You have to understand this well, and you're going to copy each and every line which I am going to tell you. Even if you have notes which have been given to you, right? I would want that what I am telling in menstrual cycle, you make notes in your own handwriting, right? Okay. So let's begin with menstrual cycle. Now, before I begin with menstrual cycle, let us revise a few things which we did when we were doing fundamentals in OBS. Now, when we were doing fundamentals in OBS, I told you that oogenesis, it begins in the intrauterine life, right? Now, when oogenesis begins, the oogonia, it gets converted into primary oocyte, right? And the primary oocyte, then it undergoes meiosis 1, right? And it has to get converted into a secondary oocyte and first polar body, right? But this meiosis 1, it gets arrested, right? And it gets arrested in which phase? All of you know that. It gets arrested in the diplotin stage of prophase, right? Now, this arrested primary oocyte. So imagine there is a female, a newborn child, right, in whom if you are opening the ovary, right, what are you going to see? You will see that all the oogonia, they would have got converted into primary oocyte, but the primary oocyte are unable to get converted into secondary oocyte because the meiotic division has got arrested, right? And this arrest, it is over only at the time of puberty. It is only at the time of puberty that the primary oocyte will get converted into secondary oocyte. So, in a newborn female's ovary up till puberty, right, what am I going to see? I am going to see that the ovary has a number of primary oocytes, right? Now, if you look at the histology of the ovary, so in the ovary, we have two main parts. One is the cortex and the other is medulla. The outer part is the cortex and inner part is medulla, right? Now, in the cortex, you are going to get these primary oocytes, right? And in the cortex, we have got follicular cells. We have some follicular cells. Now, these follicular cells which are present in the cortex, right? These are the granulosa cells. Right, now these granulosa cells, they will surround this primary oocyte, right, because the follicular cells were present in the cortex and the primary oocyte is also present in the cortex. So this the granulosa cells, they will surround the primary oocyte. Now, in the center we have medulla, right? In the medulla, blood vessels are present, plus in the medulla, certain stromal cells are present. And the stromal cells which are present in the medulla, one of them are the theca cells, right? Now, these theca cells which are present in the medulla, they also go and they surround the primary oocyte, right? So, this structure, I am just going to make an enlarged view of this structure. This structure is a primary oocyte, right? And this primary oocyte is surrounded by granulosa cells and it is surrounded by the theca cells, right? These are the theca cells and these are the granulosa cells, and we have the primary oocyte. This structure is called as a primordial follicle. This is a primordial follicle. So when you will see the ovary of a young female before puberty, right, of a female child, you will see that in her ovary there are a number of follicles, right? And what is a follicle? A follicle is a primary oocyte which gets surrounded by the granulosa cells and by the theca cells, right? Now, these follicles, they are considered as the reservoir of the ovary. So, ovary is a reservoir of many such follicles. Now, if you remember my lecture in OBS, I told you that number of follicles, they are maximum at 5th month of intrauterine life. So, I'm sure you must have understood what a follicle is now, right? Now, the number of follicles, it was maximum at 5th month of intrauterine life. I know some of you might be thinking that I'm repeating these things. I'm repeating so that you understand the line which I'm going to tell you now, right? Then, at the time of birth, and at that time at 5th month of intrauterine life, the number was 6 to 7 million follicles, right? At the time of birth, there are 1 or 2 follicles, 1 or 2 million follicles, right? Then at the time of puberty, there are 4 to 5 lakh follicles. Now, what I am seeing here is that the follicles, they are continuously decreasing, right? They were maximum at 5th month of intrauterine life. Then they are decreasing at the time of birth, and by the time they reach puberty, they are further decreasing. This means the follicles are undergoing apoptosis, and all of us know that the hypothalamic pituitary ovarian axis, it becomes functional only at the time of puberty. This means even before the hypothalamic pituitary ovarian axis became functional, the follicles are continuously undergoing atresia every month beginning from the intrauterine life, right? So they are continuously, they are decreasing. This means that who is deciding? Is any hormone deciding that these are the follicles which are going to undergo atresia? No, no hormone is deciding which follicles are going to undergo atresia, right? Hormone influence comes only at the time of puberty. But this event is happening before puberty also. So one very important line which you have to remember is that the initial recruitment of follicles is hormone independent. No hormone decides that which follicles are going to undergo atresia or apoptosis, right? And this was a PGI question. They had asked all of the following statements are correct except, and one of the statement was that the initial recruitment of follicles is hormone independent, and that's a right statement, right? So the initial recruitment of follicles is hormone independent. Clear? Right. Now, what happens at puberty? At puberty, the hypothalamic pituitary ovarian axis of a female, it becomes functional. Right? Now, because the hypothalamic pituitary ovarian axis becomes functional, from the hypothalamus, GnRH is released, and this GnRH is released in a pulsatile manner, right? Now, this GnRH will act on the anterior pituitary, and from the anterior pituitary, it will lead to the release of FSH, right? Now, this FSH is follicle stimulating hormone. Now, till now we saw that what was happening was that a number of follicles every month they were going atresia, right? And this started happening from the time of birth. At the time of birth, rather, the number of follicles was less. And by the time puberty happened, there were only 4 to 5 lakh follicles which were left. Now, when FSH is released, FSH will prevent the follicles from undergoing atresia or apoptosis. Rather, it will stimulate the follicles. That is why it is called as follicle stimulating hormone, right? So, what FSH will do? It will prevent the follicles from undergoing atresia, and it will stimulate them. Right? So, a number of follicles which were destined to undergo apoptosis, they will not undergo apoptosis, and rather they will get stimulated. Now, when I say they will get stimulated, what do I mean to say? Stimulated means that these follicles, so let's draw a follicle first. Right? This is a primary oocyte. The granulosa cells and the theca cells, right? So, a primary oocyte, granulosa cells and theca cells. Now, by stimulated, I mean that FSH will act on the granulosa cells, and from the granulosa cells, it will release estrogen and inhibin, right? So, what is going to happen is FSH will act on the granulosa cells of the follicles which got stimulated, and from their granulosa cells it will release two hormones. Number one, it will release estrogen, and number two, it will release inhibin. And which inhibin? Inhibin B, right? Now, before I go any further, let us talk about this much part. This much part I am telling you that the follicles which were about to undergo apoptosis have been stopped by FSH, right? And FSH is acting on the granulosa cells of these follicles. In other words, if I ask you my question number 1, and that is, where are the receptors of FSH present in females in the ovary? So, in the ovary, on which cells are the receptors of FSH present? FSH receptors, they are present on granulosa cells. That's one very important question. Question number 2. Now, my question number 2 is, suppose there is a female who has a granulosa cell tumor of the ovary, right? Now, if the female has a granulosa cell tumor of the ovary, and because granulosa cells produce estrogen and inhibin B, so this granulosa cell tumor of the ovary will also be producing estrogen and inhibin B. And because it will be producing estrogen, that is why a granulosa cell tumor of the ovary is a feminizing tumor of the ovary, right? So, question number 2. Granulosa cell tumor of the ovary, it is a feminizing tumor, right? Now, apart from producing estrogen, what other hormone is being produced by granulosa cells? The other hormone which is being produced by granulosa cells is inhibin B, right? So, this means if I ask you what is the tumor marker for a granulosa cell tumor of the ovary, you will say, ma'am, the tumor marker is inhibin B, right? So, question number 3. Tumor marker for granulosa cell tumor of ovary is inhibin B. Clear? Now, what is going to happen? Now, once this inhibin B is released, inhibin, whether it is released in a male or whether it is released in a female, every time this inhibin has only one function. And what is that one function? Inhibin always has a negative feedback on FSH. So, it will go to the FSH and it will decrease it. It has a negative feedback on FSH. Right? On the other hand, when this estrogen is produced, this estrogen will perform 3 functions. And what are the 3 functions which are performed by estrogen? These three functions which are performed by estrogen are, number one, it will have a negative feedback on FSH. That's number one function. Number two, it will have a positive feedback on LH. Right? And number three, it will act on the endometrium of the uterus and it will proliferate it. Proliferate the endometrium of the uterus. So first let's talk about its number three function. I am saying that when you give estrogen, it proliferates the uterine endometrium. So estrogen, in other words, can lead to endometrial hyperplasia and it can lead to endometrial cancer. This is the reason why you should never give estrogen alone to a female whose uterus is intact. Right? So write down. Never give estrogen alone to a female with intact uterus. Why? It can lead to endometrial cancer and endometrial hyperplasia. Right? Now let's talk about its function number one. Its function number one was it had a negative feedback on FSH. Now what was FSH doing? FSH was preventing the so many follicles from undergoing atresia by stimulating them. And now what has estrogen done? Estrogen has decreased the levels of FSH. So all the follicles which were stimulated by FSH and were prevented from undergoing apoptosis finally will undergo apoptosis. So all the follicles will undergo apoptosis which the FSH had stimulated except one follicle. Right? And this one follicle is called as a dominant follicle. Now, why is this happening? See, if so many follicles would have got stimulated in humans also, like in cats and dogs, at one time when a female would have conceived, she would have given birth to 10 to 12 babies. Right? So this is nature's way of having only a single baby, that there is only one follicle which remains, rest all the follicles undergo atresia. Right? Now, who decides that this is the one follicle which is going to remain? The follicle which will have maximum receptors of FSH on the granulosa cells, that will sustain. Rest all follicles will undergo atresia. Right? So, because there is a negative feedback on FSH, all the follicles which were stimulated, they undergo atresia except one, and that one follicle is called as the dominant follicle. Right? It is this dominant follicle which has maximum receptors of FSH. And that follicle will remain. Rest all follicles are going to die. So we have talked about its function number one. We have talked about its function number three. Now let's talk about the function number two. That was it had a positive feedback on LH. So I'm taking this on next slide. If you want, just put an arrow and continue there only. Now what happens because of the positive feedback on LH? Now, because estrogen has a positive feedback on LH, so the levels of LH will increase. Right? Now, the levels of LH which are increasing, this increase is a sudden increase, and this is called as LH surge. Right? So this increase is happening because of, this increase is happening suddenly, and this is called as LH surge. So if I ask you, why is LH surge happening? You will say, ma'am, LH surge is happening because of the hormone estrogen. Right? So LH surge is initiated by, so by which hormone is an LH surge initiated? It is initiated by estrogen, number one. Number 2 point is that it is estrogen, it will have to attain a peak and then only it will be able to initiate the LH surge. right? So estrogen levels, they have to be 200 picograms for 48 hours, and then only LH surge will happen, right? So estrogen levels will also have to increase suddenly, and they will have to become 200 picograms, which will have to be maintained for 48 hours. Then LH surge is going to happen. Clear till here? Now, it is because of this LH surge that what is going to happen is, see, continue your LH surge, make an arrow below that. Because of this LH surge, the meiosis 1 will get resumed. Right? So, the primary oocyte which got arrested, right, in meiosis 1, that meiosis, the division wasn't able to complete. Now, with the onset of LH surge, the meiosis 1 is resumed. Right? That is one thing which you have to remember. Now, this meiosis 1 is getting resumed because of which hormone? It is getting resumed because of LH. In other words, meiosis 1 is hormone dependent. Another very important question. This is hormone dependent. Right? Now, when the meiosis 1 will get resumed, what will happen? The primary oocyte, it will get converted into secondary oocyte. And all of us know that this conversion is called as ovulation. So we say that it is because of meiosis 1, that it is because of LH surge that ovulation has happened. Right? And what will happen to the follicle? Right? Primary oocyte, yes, it has got converted into secondary oocyte. What happens to the follicle? The follicle gets converted into corpus luteum. Right? So, I am telling you that FSH led to the release of estrogen. This estrogen led to LH surge. Right? It had a positive feedback on LH. It led to LH surge, and it is this LH surge because of which the meiosis 1 gets resumed and the primary oocyte gets converted into secondary oocyte. In other words, ovulation happens. So, ovulation is occurring because of LH surge. Meiosis 1 is getting resumed because of LH surge. Right? Now, just now, let's keep it till here. We will discuss a few more details, but just now till here. Let us discuss the other sides. Now, because one thing, this happened. Now, second thing, what is happening? Now, when this LH will increase, this LH, it is going to act on theca cells, right? And from theca cells, it will produce androgens, right? So, LH acts on theca cells, and these theca cells, they produce androgens, right? Now, these androgens, which are produced by the theca cells, they will go into the granulosa cells, and with the help of enzyme aromatase, they get converted into estrogen, right? So, LH acted on theca cells, it produced androgens, which went inside the granulosa cells and got converted into estrogen, right? Now, this conversion, it is not only happening in granulosa cells, it also happens in adipose tissue. And what is the enzyme responsible for this? The enzyme responsible for this is aromatase enzyme, right? Now, before we go any further, I want you to leave 2 pages, right? Because we will continue our cycle on those 2 pages. And on the third page, by 2 pages, I mean, I want you to leave 2 sides of the register, right? Now, on the third side of the register, especially the undergraduate students, you should understand that there is a theory which is called as the 2-cell 2-gonadotropin theory. Right. According to the 2-cell 2-gonadotropin theory, we have 2 cells. One is the theca cells and the other is granulosa cells. Right? Now, there are a few things which are lacking in theca cells and there are a few things which are lacking in granulosa cells. Number one, in theca cells, aromatase enzyme is absent. Right? But what is present in theca cells? CYP17 is present in theca cells. In granulosa cells, aromatase is present, but CYP17 is absent. Right? Now, because both these cells are lacking something and both these are having something, that is why it is believed that in order to produce estrogen, ovary needs a combined action of both these cells. That is why it is two cell. And because on both these cells, there are two different gonadotropins which act. That is why it is two cell, two gonadotropin theory. For example, in theca cells, which gonadotropin acts? LH acts on theca cells. So, on the theca cells, we have the receptors for LH. Now, LH will bind to the receptor which is there on the theca cells, and in the theca cells, with the help of cyclic AMP, it will help in the conversion of cholesterol to the androgens, that is androstenedione and testosterone. Right? Now, these androstenedione and testosterone, both of them, they will go into the granulosa cell. Right? So, the enzyme, the main enzyme which was needed for the cholesterol to get converted into any of these was CYP17. That was the main enzyme. So, because theca cells has CYP17, so it is able to manufacture cholesterol. So, it is not that cholesterol directly becomes androstenedione and testosterone. Initially, cholesterol will get converted into pregnenolone and then it will get converted into the other products, and finally androstenedione and testosterone will be produced. Right? Now, this androstenedione and testosterone which are produced in the theca cells, they will go into the granulosa cells. Now, in the granulosa cells, there are receptors for FSH. So, FSH will bind to the receptors of the granulosa cells, and in the granulosa cells, the enzyme which is present is aromatase. It is with the help of this aromatase that the androstenedione will get converted into E1 and testosterone will get converted into E2. Right? And that is how estrogens are produced by the granulosa cells. And that is why we say that FSH acts on the granulosa cells to produce estrogen. Right? But it cannot do this alone if LH is not present. LH and FSH both are playing a very important role in production of estrogen. Right? Though both have a very separate role. LH leads to the release of androgens from the theca cells which go into the granulosa cells, and with the help of enzyme aromatase, it gets converted into estrogen. This is the two-cell, two-gonadotropin theory. Right? Now, this same reaction, it also occurs in adipose tissue. Right? In adipose tissue. Now, in adipose tissue, it is basically the androstenedione which gets converted into E1 with the help of enzyme aromatase. So, the main hormone which is formed in the granulosa cells when androgens get converted into estrogen is E2. Right? But when androgens are getting converted into estrogen in adipose tissue, then the main hormone which is formed is E1. Right? That is one thing which you have to remember. right? Now let us go back to our flowchart. So in the flowchart, I made you write that LH will act on theca cells. It will produce androgens. These androgens, they will go inside the granulosa cell, and with the help of enzyme aromatase, they will get converted into estrogen, and this reaction also occurs in adipose tissue, right? Now, third thing is this LH, it will also act on the granulosa cells. And in the granulosa cells, it is going to bring about luteinization. It brings about luteinization of the cells, and from the cells, it releases small amounts of progesterone. Small amounts of progesterone are released by LH from the granulosa cells even before ovulation. At the time of LH surge. So at the time of LH surge, this LH will go into the granulosa cells and it will produce small amounts of progesterone, right? Now, a few important concepts which you will have to remember. So this means if I ask you that in females, LH receptors are present on, you will say that LH receptors are present on theca cells, because on theca cells LH acts and it produces androgens, and LH receptors are also present on granulosa cells, whereas FSH receptors were present only on granulosa cells, right? So it is present on theca cells plus it is present on granulosa cells, right? Now, second thing is, if I ask you that when is progesterone produced earliest in the menstrual cycle, you will say that progesterone appears earliest in menstrual cycle at the time of LH surge. And when we will be talking about more in detail about LH surge, I will tell you that the time duration between LH surge and ovulation is 32 to 36 hours. This means that earliest progesterone can be detected in a menstrual cycle 32 to 36 hours before ovulation. That is 32 to 36 hours before ovulation. Right? Now, continue your table there, continue your chart. Now, what happens because LH is producing progesterone from the granulosa cells, and these are small quantities of progesterone. This small quantity of progesterone, see, whenever progesterone is in low concentrations, so in low concentration, progesterone has a positive effect on LH and it has a positive effect on FSH. So because progesterone is released in small concentrations, in small concentration, progesterone always has a positive effect on LH and positive effect on FSH. So the levels of LH increase and levels of FSH increase, right? So let's think about it once again. What happened? Estrogen led to the release of LH. One, because LH levels suddenly increased, that was called as LH surge, and this LH surge led to ovulation. Another thing what LH did was LH acted on the theca cells, and from the theca cells it produced androgens which went inside the granulosa cells and it led to the formation of estrogen. Right? Third thing what LH has done is it has acted on the granulosa cells and produced small quantities of progesterone even before ovulation at the time of LH surge. Right? And this small quantity of progesterone, whenever it is produced in small quantities, progesterone in turn has a positive effect on LH and a positive effect on FSH. So the levels of LH and FSH both increase. So in other words, there is Now, this line is important. There is LH plus FSH surge before ovulation. Very, very important. So there is not only LH surge before ovulation, there is LH and FSH surge before ovulation. Right? Now, before we continue any further, where you had written the 2-cell, 2-gonadotropin theory, below that, let's start making a line diagram of the menstrual cycle and see what all we have done till now, right? So go back to this 2-cell, 2-gonadotropin theory. Below that, you will have a lot of space. Now, start making a line diagram. Line diagram of menstrual cycle, right? This line diagram of menstrual cycle will need around half a page. You will need half a page to draw this diagram, right? And side by side, we will also do questions which are asked in the menstrual cycle up till here, right? So draw the line diagram in half a page and in the other half, start writing what I'm telling you, right? Okay, now, this is day 1 of the cycle. Right, this is day 28 and this is day 14, right? Now, on day 1, we had the follicle in which there was a primary oocyte which was surrounded by granulosa cells and it was surrounded by the theca cells, right? Now, first thing what happened was FSH came and FSH acted on granulosa cells. That was the first thing to happen. So, if I ask you, write down this question. Ovarian cycle, so these are important questions. Ovarian cycle is initiated by, so ovarian cycle is initiated by the hormone FSH, right? Now what is going to happen? From the granulosa cells, FSH is going to release estrogen. This estrogen, it will have a negative feedback on FSH. It will act on the uterine endometrium and it will proliferate it. And it will have a positive feedback on LH, right? Now, because estrogen had a negative feedback on FSH, so all the follicles undergo atresia except one, and that one follicle will be called as dominant follicle, which will continue to increase in size. So, we have this dominant follicle which will continue to increase in size, right? Now, another thing what is happening is estrogen is having a positive feedback on LH. Now, because estrogen is having a positive feedback on LH, so the levels of LH will suddenly increase, right? And this will be called as LH surge. So, the levels of LH suddenly increase and this is called as LH surge, right? Now, because of this LH surge, on day 14, ovulation occurs. In other words, primary oocyte gets converted into secondary oocyte and the follicle gets converted into corpus luteum. Right? Now, let's talk about a few questions. One question which they ask you is, what is the size of the follicle? Now, this follicle has got different names. The dominant follicle which is growing in different stages, it will have different name. It will be called as the preantral follicle, the antral follicle and the Graafian follicle, right? So, they can ask you as follicle or they can ask you as Graafian follicle or antral follicle. So, what is the size of the follicle just before ovulation? Right, so the size of the follicle just before ovulation is 18 to 20 millimeters, right? So where you are writing questions, right there. The size of the follicle just before ovulation is 18 to 20 millimeter, right? Next question. As I told you, estrogen levels should be 200 picogram for 48 hours, then only LH surge occurs, right? Next question. What is the time interval between LH surge and ovulation? Now, the time interval between LH surge and ovulation, the best answer is 32 to 36 hours. And the second best answer is 24 to 36 hours. If 32 to 36 hours is not given, then you are going to say 24 to 36 hours. Right? Now, I want you to go back to your line diagram. Look here. LH surge means we are talking about time interval starting from here and going up till here. Right? This was the place where LH surge had began. And this time interval is 32 to 36 hours. But if they ask you what is the time interval between LH peak, this is LH peak. Right? This interval if they are asking you. The time interval between LH peak and ovulation, that is 10 to 12 hours, right? So write down time interval between LH peak and ovulation is 10 to 12 hours, right? Now, draw this diagram here. This over here is ovulation, right? This is our LH peak, right? Before LH peak, the estrogen peak will occur, right? So this is LH and this is estrogen, right? I am telling you time interval between LH peak and ovulation is 10 to 12 hours. Now the time interval between estrogen peak and, time interval between estrogen peak and LH peak, right? This is 14 to 24 hours, right? So write down time between estrogen peak to LH peak is 14 to 24 hours. In other words, if I say what is the time between estrogen peak and ovulation, when you add 14 to 24 plus 10 to 12, the answer comes out as 24 to 36 hours. Now, let's make these things a little simpler for you. You have to remember only three values. One value is if they ask you what is the time interval between LH surge and ovulation. So you know best answer is 32 to 36 hours. Second best answer is 24 to 36 hours. It means in my mind I have 24 to 36 also. Number two, they can ask you what is the time interval between LH peak and ovulation, and the time interval between LH peak and ovulation is 10 to 12 hours. Third question, time interval between estrogen peak and ovulation, 24 to 36 hours. So you have to remember only three values, 32 to 36, 24 to 36, 10 to 12. Clear? Okay. Now, next thing. If I ask you this question that LH surge is initiated by, you will say, ma'am, LH surge was initiated by estrogen. Because when estrogen levels increased and they reached 200 picograms for 48 hours, then it led to LH surge. But what is happening in a menstrual cycle is that once this LH surge happens, it leads to the formation of progesterone from the granulosa cells. And what does progesterone do? Progesterone leads to, it has a positive effect on LH and FSH. Right? So progesterone leads to both LH and FSH surge, right? In other words, if I ask you, LH surge is maintained by, so it was initiated by estrogen, but it is maintained by both estrogen and progesterone. Clear? Next question. If I ask you, before ovulation, there is, and your options are option A, LH surge, option B, FSH surge, option C, LH and FSH surge, and option D, none. Right? So, you know, before ovulation, what is there? Before ovulation, there is both LH and FSH surge. Clear? Next question. If I ask you, ovulation is due to. Now, when we say ovulation is due to, and you have the same options, right? Then your answer will be option A, that is LH surge. Then you will not say that ovulation is due to both LH and FSH surge. No. Before ovulation, there is LH and FSH surge, but ovulation happens due to LH surge. Right? Now, I was telling you that meiosis 1 is resumed due to LH surge. In other words, meiosis 1 is resumed 32 to 36 hours before ovulation. Right? Because LH surge happens 32 to 36 hours before ovulation. Right? Similarly, if I ask you, when can progesterone be earliest detected in a menstrual cycle? Earliest progesterone can be detected 32 to 36 hours before ovulation, because progesterone is produced, earliest progesterone is produced due to LH surge. Right? So this was the first half of the menstrual cycle. Right? Now, in the first half of the menstrual cycle, as you can see, whatever is happening to the follicles. Initially, the follicles underwent atresia, a single follicle was left, and this single follicle started growing, right? And it reached maximum size, that is 18 to 20 millimeters. So, in the first half of menstrual cycle, whatever is happening to the follicle. That is why first half of the menstrual cycle is called as follicular phase, right? Another thing, in the first half of menstrual cycle, which is the main hormone? The main hormone in the first half of menstrual cycle is estrogen. And what is estrogen doing to the endometrium? Estrogen is proliferating the endometrium. That is why first half of the menstrual cycle is also called as proliferative phase. Right? So this was about first half. Now ovulation happened, right? And when ovulation happened, the primary oocyte got converted into secondary oocyte and a corpus luteum is formed from the follicle. Now let's talk about corpus luteum. Right now, like I was telling you, we're going to talk about corpus luteum. But before I talk to you about corpus luteum, just one more thing which I want you to note, right? So where we were talking about all the questions, you had written important one-liners there. See, the other thing which you should note here about the follicles is, I am telling you that there is only one follicle which continues to grow, and that becomes the dominant follicle during the follicular phase, right? So we have one follicle which was initially very small, and it was a primary oocyte, and it was surrounded by the granulosa cells, right? Now this, later on, it is going to become big, right? And in this, a cavity will appear. Right? Initially, the cavity will be small, and then the follicle will be called as a preantral follicle, and then the cavity will become large, and this will be called as a antral follicle. Right? So, I am directly drawing antral follicle for you. So, over here, this is our primary. So, suppose this was the primary oocyte. So, this is our primary oocyte. Right? This is the cavity which has appeared, and this is called as the antral cavity. This is the antral cavity, right? And it will be surrounded by the granulosa cells. Now, there are certain granulosa cells which will come and surround the primary oocyte directly. I am drawing them with a different color. I am drawing them with a pink color, right? So, the granulosa cells which surround the primary oocyte in the follicle, these cells are called as cumulus euphoricus, right? And that's a very important question, that what is the name of the granulosa cells which surround the primary oocyte in a follicle? That is cumulus euphoricus, right? Another thing. Now, in this antral cavity, estrogen will be present, plus growth factors will be present. The fluid of the antral cavity, it will have estrogen and growth factors, right? Now, LH comes in the antral cavity fluid only in the mid of the cycle. LH comes in the fluid of antral cavity towards the mid of the cycle, right? After LH surge, the LH will also come into the antral cavity fluid. Now, suppose if LH is present in the fluid of antral cavity from the very beginning. Now, if LH is present in fluid of antral cavity from the beginning, from early in the cycle, now, then what is going to happen is, because it is present from early in the cycle, it is going to lead to degeneration or atrasia of the granulosa cells. It will stop the mitotic activity of the granulosa cells and it will lead to the atrasia of the follicles. And this is exact what happens in PCOS. In PCOS patients, the levels of LH hormones, they are raised from the beginning of the cycle, and because they are raised from the beginning of the cycle, LH is present in the antral fluid from the beginning of the cycle, and so what it does, it decreases the mitotic activity of the granulosa cells and it brings about atrasia of the follicle, and both these things, they result in anovulation, and now the follicle cannot ovulate. The primary oocyte cannot get converted into secondary oocyte. Right? So, this is the mechanism for anovulation in PCOS patients, right? Now let's talk about the normal phenomena. Normal phenomena was LH surge had happened and that had led to ovulation. So, we are continuing our flowchart. You have to continue your flowchart. Go to your flowchart, continue the flowchart. Now, in the flowchart, what you had written? You had written that primary oocyte had got converted into secondary oocyte, that was called as ovulation in the left hand side, and the follicle had got converted into corpus luteum. Now what is going to happen? Continue. So if you don't have space, as I also don't have space, you can continue it on any other page. I am writing this here for you. The primary oocyte, it got converted into secondary oocyte and the follicle got converted into corpus luteum, right? Now, so we have a corpus luteum which is formed. Now tell me, why is corpus luteum being formed? Corpus luteum is being formed because of ovulation, right? Because the follicle after ovulation is getting converted into corpus luteum, right? And why is ovulation happening? Ovulation is happening because of hormone LH. In other words, corpus luteum is there because of hormone LH. If LH is there, corpus luteum is there, right? So, if I ask you, which hormone maintains corpus luteum? Which hormone maintains corpus luteum in a non-pregnant female? You will say LH. So, corpus luteum, LH, luteinizing hormone. That is why it is called as luteinizing hormone. Now, under the effect of LH, this corpus luteum starts growing, right? So now what happens? Corpus luteum, it starts growing under the effect of LH, right? Due to LH, right? And this corpus luteum, it reaches maximum size and maximum activity. That's a very, very important question. It reaches maximum size and maximum activity 8 days after ovulation, right? So 8 days after ovulation, corpus luteum is going to attain maximum size and maximum activity, right? Now let us see, draw this much on our line diagram. In this line diagram, we did till ovulation, and I told you that the primary oocyte is getting converted into secondary oocyte and the follicle is getting converted into corpus luteum. So let us draw our corpus luteum. So this purple color, what I am drawing is corpus luteum. Now I am telling you that under the effect of LH, this corpus luteum starts growing, right? And 8 days after ovulation, this corpus luteum has maximum size and activity. Now 8 days after ovulation means which day of the cycle? Day 22 of the cycle, right? So go back and write there, which is equal to day 22 of the cycle. Now this corpus luteum, it releases 3 hormones, right? Mainly the hormone which is released by corpus luteum is progesterone. Mainly it releases progesterone. Apart from progesterone, it releases estrogen and it releases inhibin A, right? Inhibin B was released by granulosa cell. Inhibin A is being released by corpus luteum. Now the function of estrogen and inhibin A remain the same. That is, they decrease the levels of FSH. Let's concentrate on progesterone. But before talking about progesterone, suppose you get a question which says corpus luteum secretes, and in the options you have option A estrogen, option B progesterone, option C both, option D none. What are you going to mark? Both, right? But if your question is corpus luteum mainly secretes and the same options are there, then you are going to write the answer as progesterone, because mainly corpus luteum secretes progesterone, right? Now another thing, corpus luteum of pregnancy, apart from secreting these 3 hormones, it also secretes one more hormone, and that is relaxin, right? Normally it will not secrete relaxin, but during pregnancy corpus luteum secretes relaxin. Clear? Now this progesterone, when it is released, it will do 2 things. It will have 2 functions. Right? Now before I tell you the functions, see, FSH was acting on granulosa cells, and from FSH estrogen was produced, right? The moment estrogen was produced, it had a negative feedback on FSH. Now progesterone is being produced from corpus luteum under the effect of LH. So the moment progesterone is produced, it will have a negative feedback on LH. So one function is it will have a negative feedback on LH. That is one thing which it is going to do, right? And the second thing what it is going to do is, what estrogen was doing, it was proliferating the endometrium, right? And proliferated endometrium is very, very weak. So when progesterone comes, it supports the endometrium, it stabilizes the endometrium, it acts like a cement and it holds that endometrium, right? This is called as secretory action, right? So the second work of progesterone is it acts on the uterine endometrium and it supports it. This is called as the secretory action. Have you understood till here? Let's talk a little bit more about first function. So I am seeing here two things in the cycle I understood. That in the first half of menstrual cycle, progesterone was there, but it was in less quantity. And when it was in less quantity, ma'am told me that it is going to increase the levels of LH. Now in the second half of menstrual cycle, progesterone is it is the most important hormone. It is in maximum concentrations. And now ma'am is telling it is decreasing LH. And that is exactly how progesterone acts. Right? So write down here an important concept. The concept is at low concentrations, progesterone increases LH and increases FSH. At high concentration, progesterone decreases LH and decreases FSH. Nothing to mark. This is something which you understood just now, right? Now, I have told you here just now that corpus luteum is formed because of hormone LH, and it is growing because of the hormone LH. And this very LH is being decreased by progesterone, right? So when the levels of LH decrease, corpus luteum also starts degenerating, right? A very, very simple relationship between them. You go, I go, right? So the moment LH starts decreasing, corpus luteum, the size of corpus luteum starts decreasing and it starts degenerating, right? So because there is negative feedback on LH, so the levels of LH decrease, and because the levels of LH decrease, corpus luteum starts degenerating. Right? Okay, till here understood? Now, when corpus luteum will degenerate, all the hormones which are formed by corpus luteum will decrease, right? In other words, what will decrease? Progesterone will decrease, estrogen will decrease, and inhibin A will decrease, right? Now, I told you that one of the work of progesterone here, I told you that progesterone was acting as a cement and it was holding the endometrium. Now, when the levels of progesterone decrease, what happens? This endometrium, which the progesterone was holding, it sheds. Right? Now, because there will be no cement-like material now and it will shed. Right? So, what is going to happen? When progesterone decreases, two things happen. The support to the endometrium is lost. Right? And the endometrium is shed. And this shedding of endometrium is called as menstruation. Right? Now, when you will do anatomy with me, there I'll tell you that it is this endometrium, uterine endometrium, has two important layers. One is the superficial layer and the other is deep layer. The deep layer is called as the zona basalis or the stratum basalis. Right? Now, when I say that endometrium sheds, it is not this that the superficial layer will also shed and the deep layer will also shed. No. It is only that the superficial layer, it sheds at the time of menstruation. Right? So, what is happening at the time of menstruation? The superficial layer of the endometrium is getting shed. Have you understood? Now, second thing, understand. When progesterone decreases, right, why is it that the endometrium is shed? The endometrium is shed because the support is lost and there is an important enzyme which is released here. The enzyme which is released here is metalloproteinase enzyme. This metalloproteinase enzyme leads to the shedding of endometrium. Clear? Now, second thing what happens is, this was first thing. Second thing what happens is that progesterone is a smooth muscle relaxant. This we have been doing throughout OBS. I've been telling you that. Now, when the levels of progesterone decrease, vasoconstriction occurs. Vasoconstriction occurs, and because of vasoconstriction, PGF2 alpha is released. Right? Now, this PGF2 alpha, it leads to increase in the contractions of the myometrium, and that is what leads to pain during menstruation. So, it increases the myometrial contractions or spasms, and that leads to pain during menstruation, which is called as dysmenorrhea. Right? Clear? So why dysmenorrhea happens? Dysmenorrhea happens because PGF2 alpha was released. So if I ask you which is the main prostaglandin which is released during menstruation, it is PGF2 alpha. Clear? Now, not only is progesterone decreasing, you can also see that estrogen is decreasing and inhibin A is decreasing. Now, what were the role of estrogen and inhibin A? Estrogen and inhibin A, they were having a negative feedback on FSH. Now, when estrogen will decrease and inhibin A will decrease, the levels of FSH will increase. The levels of FSH increase as the negative feedback is gone. Right? Now what is going to happen? Now again the entire cycle will start. FSH will again act on the granulosa cells, and from the granulosa cells again it will release estrogen. So again it acts on the granulosa cells, and from granulosa cells it releases estrogen. Right? Again this estrogen acts on the uterine endometrium and it proliferates it. Again, it has a negative feedback on FSH and it has a positive feedback on LH. And again, the entire cycle is repeated. Now, why I'm repeating this here, writing this here is because there was 3 roles of estrogen. One role of estrogen was it had a negative feedback on FSH, it had a positive feedback on LH, and third thing was it proliferated the uterine endometrium. Now, this estrogen which is released, which I am telling you that it proliferates the uterine endometrium. Which endometrium is it going to proliferate? See, superficial is shed. What is left inside the uterus is the deep layer. So, estrogen in the next cycle will act on the deep layer and it will proliferate the deep layer. Deep layer again will form superficial layer, right? And again at the time of menstruation, the superficial layer will be shed and deep layer will remain inside. So one very important question which they ask you is, which layer of endometrium is responsible for regeneration of entire endometrium in the next cycle, right? Which layer is responsible for regeneration of the entire endometrium in the next cycle? You will say it is the deep layer, that is zona basalis. Have you understood menstrual cycle? Right? So I have tried to simplify this as much as possible. Now, before we end menstrual cycle, again, we will go back to the line diagram. We will complete the line diagram and we will write some more important questions, one-liners on the menstrual cycle, right? So go back to your line diagram. Now, in this line diagram, you had drawn that on day 22, corpus luteum has maximum size and maximum activity, right? This was the corpus luteum. Now, this corpus luteum, it produces mainly progesterone. Apart from that, estrogen and inhibin A, right? Now, this progesterone which it produces, this progesterone will have two functions. This progesterone will act on the uterine endometrium and it will bring about secretory action, right? And this progesterone will decrease LH. Now, because progesterone will decrease LH, the size of the corpus luteum starts decreasing because the LH is decreasing, and ultimately when there will be no LH, then corpus luteum will totally degenerate. So, the size of the corpus luteum decreases, right? When the size of the corpus luteum decreases, the levels of progesterone decrease and the support to the endometrium is lost, and this is how on day 28 a female menstruates, right? So this is your entire menstrual cycle. Now, if you see here in the second half of the menstrual cycle, whatever is happening to the corpus luteum, right? Initially, corpus luteum is growing in size till day 28 and then it is decreasing in size, right? That is why the second half of the cycle, it is called as luteal phase, right? And another thing, in the second half of the cycle, which is the main hormone? The main hormone in the second half of the cycle is progesterone. And what does progesterone do to the uterine endometrium? It brings about secretory action. That is why second half is also called as secretory phase, right? First half is follicular phase, second half is the luteal phase, right? First half can also be called as proliferative phase and the second half can also be called as secretory phase, right? Now suppose I don't know anything about a defect which is luteal phase defect. I just get a question which says that a female is having recurrent abortions and the reason for abortion is luteal phase defect. What is the drug of choice? Now, I haven't read this luteal phase defect, but I know that in luteal phase, the main hormone which is there is progesterone. So this means that in this female, there is less progesterone and that is what is leading to abortions, right? So what will become the drug of choice? Progesterone, right? Okay. Now, first let's complete all the questions right here. So go back to your important questions and let's complete them. So the question, next question, in the first half of the cycle, which was the main hormone? The main hormone was estrogen. In the second half of the cycle, which is the main hormone? The main hormone is progesterone, right? Next. Now, in a menstrual cycle, as I told you, the first half is called as follicular phase, second half is called as luteal phase, right? This is day 1, day 14, day 28. Now, it is the luteal phase which is fixed. It has a fixed duration and the duration is fixed to 14 days. Right, on day 14, ovulation was happening. So it is the luteal phase whose duration is fixed to 14 days. If in a female, the cycle is not of 28 days, right? In that case, it is the luteal phase whose duration will be fixed to 14 days. Follicular phase can vary depending on the cycle length. Right? Now, how is this fact important? Now, I am telling you that in a 28-day cycle, ovulation happens on day 14, right? But suppose you have a female whose cycle is not 28 days, right? Her cycle is 30 days, right? And this female says that I had my menstruation on 1st of January and I'm now expecting my menstruation on 30th of January. Doctor, I want to conceive, so I want to know on which day am I going to ovulate. Now suppose you'd say that ovulation occurs on day 14. So you tell her that you are going to ovulate on 14th Jan. Now if you say that she ovulates on 14th Jan, she is going to menstruate on 30th Jan, right? So that means the luteal phase has become for how many days? Luteal phase becomes for 16 days. And I am telling you that luteal phase duration has to be kept fixed, and that is 14 days. So that means I cannot tell her that she's going to ovulate on 14th Jan, right? So what I'm going to do is I am going to count from 30th Jan, I will count backwards, right? So I will do 30 minus 14, that is 16th Jan. I will tell her that she will ovulate on 16th Jan. Right? Because when I say she ovulates on 16th Jan, her luteal phase is of 14 days. Her follicular phase can vary. That's okay. Right? In other words, in order to calculate ovulation, what I did? I counted backwards from the next day of menstruation. Right? From the next menstruation, I counted 14 days backward. Right? I am not going to count day of ovulation forward from this time's menstruation. Right? So, how do you calculate ovulation? The day, and that's a very, very important question. The day of ovulation, very important. It is equal to, for the day of ovulation, you have to count 14 days backward from the date of next menstruation. Right? And that is how the question was asked, that ovulation occurs, and the options given were option A, 14 days after this menstruation, option B, 14 days prior to next menstruation, option C, 16 days after this menstruation, option D, 16 days prior to next menstruations. How do you calculate the day of ovulation? Day of ovulation is 14 days prior to the next menstruation, right? In other words, I can also say that the day of ovulation is the total length. So either you say like this, or you say from the total length of the cycle, you minus 14 and you get the day of ovulation, right? For example, if a female's cycle is 26 days, right? Then the day of ovulation, what will it be? She is going to ovulate 26 minus 14, that is on day 12, right? That is how you calculate ovulation, right? Now, ovulation has happened and our corpus luteum has formed. So let's talk about corpus luteum. Questions which they ask on corpus luteum. Number 1, as I told you, which is the hormone which maintains corpus luteum in non-pregnant female? In a non-pregnant female, corpus luteum is maintained by hormone LH. I'm writing it with a different color, hormone LH, right? Question number 2, hormone which maintains corpus luteum in a pregnant female. In pregnancy, we did that it is hormone HCG, and that is why we say LH and HCG are functionally the same, right? Now, in your line diagram, you see that the corpus luteum was formed on day 14, right? It then increased in size, it then decreased in size, and finally by 28 days, menstruation has happened. Menstruation happened means that the corpus luteum has already degenerated, right? So if I ask you that what is the lifespan of corpus luteum in a non-pregnant female, your answer will be that, ma'am, it was there till 14 days and by 14 days menstruation has also happened. That means roughly the lifespan of corpus luteum would be 10 to 12 days, right? Because once the corpus luteum dies in 10 to 12 days, the levels of progesterone absolutely decrease, and by 14th day, after next 2 days, the patient menstruates, right? So, the lifespan of corpus luteum in a non-pregnant female is 10 to 12 days. And question 4, in pregnancy, it is 10 to 12 weeks, right? Now, just one more thing. Suppose this female on day 14, when she ovulated, right, at that time she became pregnant, right? Now, corpus luteum is still formed during pregnancy also. Now, that corpus luteum which is there at the time of pregnancy is called as corpus luteum of pregnancy. Now, this corpus luteum which is there because of the hormone LH, right? Now, this corpus luteum was about to die, right? But because the patient had become pregnant, this patient started producing hormone HCG, right? And this corpus luteum which was about to die, the HCG, it prevents it from dying, right? And so corpus luteum of pregnancy doesn't die, right? Otherwise, the corpus luteum would have died, right? If the female wouldn't have become pregnant. So if I ask you which hormone rescues the corpus luteum from undergoing luteolysis, it is hormone HCG. In a non-pregnant female, corpus luteum is about to die, but just because she has become pregnant, there is hormone HCG. This HCG protects it from dying, right? So, question 5. The hormone which protects corpus luteum from undergoing luteolysis, that is hormone HCG. This question is specific to the corpus luteum of pregnancy, right? So they don't say it is corpus luteum of pregnancy, but that is what is meant by it. That now the patient has conceived and HCG has protected it from undergoing luteolysis, right? Okay. Next. Before we end this topic here, let us look at a few questions related to the levels of the hormones. See, all hormones they peak at the time of ovulation. Like LH peaks at the time of ovulation, FSH peaks at the time of ovulation, estrogen peaks just before ovulation, right? But it is progesterone which peaks. At what time is progesterone peaking? Progesterone will peak at the time when the activity of the corpus luteum will be maximum. And I told you the activity of corpus luteum is maximum on day 22 of the cycle, that is 8 days after ovulation. So progesterone peaks at day 22 of the cycle, right? So suppose you have an image like this, right, in which they are saying that identify the hormone which they have shown in light purple color, right? Now see, all the hormones, they are peaking at the time of ovulation. The dark blue color is the LH, the green color is the FSH, and the orange color is estrogen, which is peaking just before ovulation, right? So we know at what time does estrogen peak? Estrogen peaks right there only. Before ovulation, how many hours before ovulation? 24 to 36 hours before ovulation, right? Now, progesterone is the only hormone which peaks after ovulation. And how many days after ovulation? 8 days after ovulation. So if they show you this image and they mark this purple color hormone as X and they ask you to identify the hormone X, you know that hormone X is progesterone because that's the only hormone which will peak after ovulation, right? Next thing. Now, because progesterone levels are maximum at day 22 of the cycle, now if I have an infertile female coming to me, right? Now, in this infertile female, I want to know whether ovulation has occurred or not. So, I know this, that progesterone is present in a female in good quantities only if a female ovulates, right? If a female doesn't ovulate, then progesterone is not present in her in good quantities, right? So, all the tests for ovulation, they are based on this very principle that if a female ovulates, progesterone is present in her body. If a female doesn't ovulate, progesterone is absent in her body, right? And if all the tests of ovulation are ultimately looking at hormone progesterone, whether it is present or whether it is not present. So if I'd ask you that all the tests of ovulation should be done on which day of the cycle, you will say, ma'am, all the tests for ovulation, they should be done on day 22 of the cycle. So this day 22, right, on the same fact, 3 types of questions can be asked. One type of question which is asked is, when does progesterone peak? That is question number 1. Question number 2, when is the size of corpus luteum maximum? Same question, 3 different ways of asking. You will say size of corpus luteum is maximum on day 22 of the cycle. Question number 3, all the tests of ovulation they are done on, so you will say all the tests for ovulation, they are done on day 22 of the cycle, right? Then, another very important thing, as I told you, that progesterone has a negative feedback at high concentrations. We did just now that at high concentration, progesterone has a negative feedback on LH and a negative feedback on FSH. So if I ask you in a menstrual cycle, when are the levels of LH and FSH minimum? You are going to say they are minimum in the secretory phase, right? So the levels of LH and FSH are minimum in secretory phase. And obviously they will be minimum when progesterone is maximum. And when is progesterone maximum? Day 22 of the cycle. So either in your questions it will be written as secretory phase, or it will be written as day 22 of the cycle, or it will be written as 1 week before menstruation. Day 22 of the cycle means approximately a week before ovulation. A week before menstruation, right? Not ovulation. A week before menstruation. Day 28 and day 22. That is 1 week before menstruation. So, if they ask you when are the levels of LH and FSH minimum in a menstrual cycle, so the answer to this question can be LH and FSH levels are minimum, right? Either in the option you can get in secretory phase, because in secretory phase progesterone is present in good quantities, or because maximum levels of progesterone are seen on day 22. So the option can say that levels of LH and FSH are minimum on day 22 because on day 22 progesterone is maximum, right? So day 22 of the cycle. At day 22 of the cycle, patient in a 28-day menstrual cycle, she is menstruating on day 28, right? day 22 means 1 week before menstruation, right? So, or it can be written as 1 week before menstruation. Either of these options can be there. That when are the levels of LH and FSH minimum, right? Then, one last question which I want to discuss with you is, some females at the time of ovulation, in a few females, at the time of ovulation, there is pain in abdomen. So these patients, they complain of mid-cycle pain in abdomen, right? This is called as Michel-Merz syndrome. Michel-Merz syndrome. Pain in abdomen at the time of ovulation. So it's a mid-cycle pain, right? So I hope you've understood the basics of menstruation, the menstrual cycle. Now, next topic, we are going to discuss more about menstruation, right? So as of now, this is what I want you to know about the menstrual cycle. Let's take up a few questions on menstrual cycle. Okay, question number 1. All of the following statements are correct except option A, LH surge is initiated due to sustained levels of 200 picograms of estrogen for 48 hours. Yes, I've repeated this 3-4 times. You know instantly it is yes. LH surge is maintained by estrogen and progesterone. Yes. LH surge is initiated by estrogen. It is maintained by both LH and it is maintained both by estrogen and progesterone. Third option, meiosis 1 is hormone. It is not meiosis, it is meiosis. Meiosis 1 is hormone dependent. Yes. Meiosis 2 is hormone dependent? No. Meiosis 2 is not hormone dependent. Meiosis 1 is hormone dependent, and it depends on which hormone? It depends on the hormone LH, right? So the answer here is option D. So this was correct, this was correct, this is wrong, right? Then next question. Granulosa cells produce estrogen with the help of which enzyme? So with the help of which enzymes do granulosa cells produce estrogen? With the help of enzyme aromatase. So the next question. The gene present in theca cell and absent in granulosa cell which enables theca cell to produce androgen. So we saw that in theca cells CYP17 was present, which was absent in the granulosa cells, and that is why theca cells were able to produce androgens from the cholesterol, right? So it is, answer is CYP17 gene. Next, in a 40 days menstrual cycle, ovulation occurs at. Now, in a 40-day menstrual cycle, in order to calculate the day of ovulation, I told you, from the total length of the cycle, you have to subtract 14, right? So 40 minus 14, and that is day 26. So the answer is day 26. So the next question. All of the following statements are true regarding estrogen except option A, it is responsible for pre-ovulatory LH surge. Yes, estrogen is responsible for that. It causes a negative feedback on FSH. Definitely. It produces proliferative endometrium. Yes. It is secreted by theca cells. No. It is secreted by granulosa cells. Right? So this is all what you need to know about menstrual cycle. Now, before I proceed with characteristics of a normal menstrual cycle, let us stick to menstruation first. Now, what was menstruation? Menstruation was the shedding of endometrium. And which layer of endometrium? The superficial layer of endometrium, right? And why was menstruation happening? Menstruation was happening because initially the levels of progesterone in the female were high and they were supporting the endometrium. And all of a sudden, the levels of progesterone fall down. And because the levels of progesterone fall down suddenly, the support to the endometrium is lost and the endometrium is shed, right? This means that the main hormone which is responsible for bringing about menstruation is progesterone. But one thing which we have to remember is progesterone cannot act unless and until the uterus has been primed by estrogen. Unless and until estrogen has initially primed the uterus, till that time progesterone cannot act. But nevertheless, the most important hormone which is needed for menstruation is progesterone. And for menstruation to occur, initially the levels of progesterone should be high and then they should fall off suddenly, right? So to understand the importance of progesterone, suppose you are sitting in an OPD and a female comes to you and she says, the doctor, I have to attend a family function or I have to attend some pilgrimage and that is the time when my menstruation is due. So please give me a drug to postpone my menstruation. Now in that case, you know that till the time in the female the levels of progesterone are high, till that time she will not menstruate, right? And the day the levels of progesterone go down, she will menstruate. So what you're going to advise her is that 2 to 3 days before her date for menstruation, she should start taking progesterone, 5 mg Primalute N TDS. So Primalute N 5 mg TDS, that is what you are going to tell her to take, right? This she will have to take 2 to 3 days before menstruation. Now till the time she is taking Primalute N, till that time the levels of progesterone in her body are high. And the day she stops taking progesterone, that is once the family function is over, once the pilgrimage is over, the levels of progesterone will go down and after 2 to 3 days, she will menstruate. In other words, the drug which I gave to postpone menstruation was progesterone, right? Now think of the reverse situation. You are sitting in an OPD and a patient comes to you. She says, doctor, I was expecting my period on the 1st of Jan and today it is 10th of Jan, but still I haven't had my periods. Now, whenever a female comes to you with a complaint that she has not had her periods for the past 10 days, the first thing which comes to my mind is it could be that she is pregnant. That is if the female is sexually active. So if she is sexually active, I will tell her to get a urine pregnancy test done. Right? Why pregnancy comes into my mind is because pregnancy is the most common cause of secondary amenorrhea, right? And this is a case where patient earlier was having menstruation normally and now she has come to you that for the past 10 days she's not had any periods. She was expecting her period on 1st of Jan. Now, why during pregnancy is there amenorrhea? See, in pregnancy, in the earlier weeks of pregnancy, the corpus luteum produces progesterone, right? And later on, the function is taken over by placenta. So throughout 9 months, the levels of progesterone in the pregnant female are high. And because the levels of progesterone in a pregnant female are high, that is why progesterone supports the pregnant endometrium, which is called as the decidua. And that is why there is no menstruation. Now, after delivery, what happens? After delivery, the placenta is out. Now, once the placenta is out, then the source of progesterone in the female's body goes. So, what happens to the levels of progesterone? The levels of progesterone in the female comes down. So, this female, when the levels of progesterone will come down, her pregnant endometrium, which is called as the decidua, the support to the decidua will be lost and decidua would be shed. And what is this called as? Shedding of decidua or pregnant endometrium after delivery. That is what is called as lochia. So basically lochia and menstruation are the same. It's menstruation, you say it in a non-pregnant female, and after pregnancy, if she is having shedding of endometrium, that is called as lochia, right? Okay. So this female who came to me, she said that on 1st of January, she was expecting her period. 10th of January has happened and today is 10th of January. She did not have her periods. First thing I tell her is go get a urine pregnancy done, a test done if she is sexually active. Now, if the urine pregnancy test comes out to be negative, now I know that in this female, if somehow I can decrease the levels of progesterone, the support to the endometrium will be lost and the endometrium will be shed. Now, the drugs which are available to decrease the levels of progesterone, they don't decrease the levels of progesterone in such a short span of time, right? They have a long half-life and they take a long time to act and they have their own side effects. So, now what I do is, to this female, I will give progesterone, Meprate 10 mg BD or TDS. And I will tell her to take this tablet of progesterone, Meprate 10 mg, for 5 to 7 days. Right? Now, till the time I am giving her progesterone for 5 to 7 days, till that time, the levels of progesterone in her body will be high and she will not menstruate. So you will have to clearly explain to the patient that when you are taking this drug, don't expect menstruation, and please don't think that the doctor was not good. I am taking the tablet also and I'm not getting any menstruation. Till the time you are taking the drug, you will not get any menstruation, right? So I will give her progesterone for 5 to 7 days. So for 5 to 7 days, the levels of progesterone in her body will be high. And after that, all of a sudden, I will stop giving her those tablets. Now, when I stop giving her those tablets, the levels of progesterone suddenly fall, right? And because the level of progesterone suddenly fall, the support to the endometrium is lost and the female menstruates. So the drug which was used to postpone menses, that was also progesterone. The drug which is used to bring about menstruation, that is also progesterone. In other words, anything and everything related to menstruation is related to progesterone. If progesterone is there, then only a female will menstruate. And for menstruation, initially it should be high and then the levels should fall suddenly. Right? So just one or two important points which I want you to write down. Number one, main hormone needed for menstruation is progesterone. For menstruation, initially the levels of progesterone should be high. And then they should fall suddenly. That is one very important thing. Number two, progesterone, it can act only on a uterus which has been primed by estrogen. Right? So progesterone can act only on the uterus which has earlier been primed by the estrogen. Third important point, if a female does not ovulate, now if a female will not ovulate, right, so there will be no progesterone. Why? Because there will be no corpus luteum. So there will be no corpus luteum. And if there will be no corpus luteum, the levels of progesterone will be very less or progesterone will be absent. In either case, when progesterone is less or progesterone is absent, I am telling you for menstruation to happen, the progesterone levels should be high and then they should decrease suddenly. So in this case, if the progesterone is absent or the levels are low, obviously the patient is going to come to you with complaint of amenorrhea, right? So no progesterone means no menstruation, right? Clear till here? Now you will ask me that, ma'am, you are saying that if a female is not ovulating, that means no corpus luteum, that means no progesterone, that means no menstruation. Fine. But so many times we read, until now we have read that anovulatory cycles are irregular, and when a female starts her menarche, at that time she has anovulatory cycles. Near menopause, she has anovulatory cycles. And you are saying that if there is anovulation, there is no menstruation. So what is this anovulatory cycle, right? So now understand. See, I am saying if there is no ovulation, there is no corpus luteum and there is no progesterone, right? Agreed. This means that in this female, there is no progesterone. But what hormone is present in this female? Estrogen, right? So in this female, if she is not ovulating, the hormone which is present in her body is estrogen, right? So now this estrogen, what does estrogen do? Estrogen proliferates the endometrium, right? So this estrogen will proliferate the endometrium, right? Now suppose there is a child, right? And this child is making a wall out of building blocks, right? And the child is going on adding building blocks. The child is going on adding building blocks, going on adding building blocks. And there is nothing to support that wall which the child is making out of that building blocks. Right? Ultimately, one day that entire wall will fall, right? Because there was nothing to support the wall. So is the case in these patients. In these patients, there is no progesterone, right? So if there is no progesterone, there is no menstruation. But on the other hand, they have estrogen. And what does estrogen do? Estrogen proliferates the endometrium. It keeps on proliferating the endometrium. And there is nothing to support this proliferated endometrium. So one day what happens is, this proliferated endometrium sheds. Right? And this is called as estrogen breakthrough bleeding. Right? So let's understand this with an example. Suppose there is a female who had her menstruation on the 1st of Jan, right? She had a 28-day cycle, and on 14th of Jan, she was expecting to have ovulation. Now, 14th of Jan, she did not have any ovulation, right? Now, obviously, if she did not have any ovulation, there is no corpus luteum and there is no progesterone, right? And if there is no progesterone, on 28th of Jan, she will not menstruate. In other words, she will have amenorrhea. Right? Now, nothing happens. 28th Jan goes, nothing happens. 5th Feb comes, nothing happens. 10th Feb comes, nothing happens. Nothing has to happen. Why? Because she has not ovulated. So there is no progesterone. So no menstruation. Now, so the time passes. 15th Feb, maybe next month, 28th Feb comes. Now, in the meanwhile, what is happening? In the meanwhile, in her body, there is estrogen, which is leading to proliferation of the endometrium, right? And this endometrium ultimately becomes so weak that this endometrium sheds. So we don't know when, maybe on 20th of Feb, maybe on 5th of March, maybe on 10th of March, this endometrium will shed, right? And this is called as estrogen breakthrough bleeding. But patient is not going to say that, ma'am, I am having estrogen breakthrough bleeding on 5th of March. What is she going to say? She is going to say that I was expecting my periods on 28th of Jan, but my period came on 5th of March. In other words, I am having irregular cycles. Understanding? So, this is the spectrum of same disease. In an ovulation patients, that is in PCOD patients, either patient can come to you with complaint of amenorrhea, or she can come to you with the complaint of irregular cycles. In other words, anovulatory cycles are irregular in nature, right? So let us write it down. So the hormone which is present is estrogen, and what does this estrogen do? This estrogen proliferates the endometrium, right? The proliferated endometrium is weak. Right? And ultimately, it sheds one day. This is called as estrogen breakthrough bleeding, right? And this estrogen breakthrough bleeding, it can occur on any day. That is the reason why anovulatory cycles are irregular. Have you understood? Right? Another thing about anovulatory cycles. See, when a female was having menstruation due to decreased progesterone, right? So, normally, what happens for normal menstruation? In a normal menstruation, the levels of progesterone, they decrease suddenly. Because the levels of progesterone decrease suddenly, metalloproteinase enzymes are released, which lead to ischemic necrosis of the endometrium. because of which the endometrium is shed. Right? Apart from this, when the levels of progesterone decrease suddenly, there is vasoconstriction. Right? Because of this vasoconstriction, PGF2 alpha is released, and this PGF2 alpha leads to increased myometrial contractions, and that leads to dysmenorrhea, that is pain during menstruation. In other words, dysmenorrhea tells us indirectly that initially the progesterone levels were high and now it has decreased. In other words, dysmenorrhea is an indirect indicator of ovulation, that ovulation has occurred. Right? So whenever a female is complaining of dysmenorrhea, one thing I know, that yes, her cycles are ovulatory cycles. Right? Now, what happens in anovulatory cycles? In anovulatory cycle, bleeding is happening because of estrogen. Bleeding is not happening because of decreased progesterone. And because bleeding is not happening due to decreased progesterone, so PGF2 alpha is not released, and that is why anovulatory cycles are irregular plus painless. Right? Anovulatory cycles are irregular and painless. Right? Third thing about anovulatory cycles. Anovulatory cycles are due to estrogen. And what were estrogen doing? Estrogen was proliferating the endometrium. And at the time when the proliferated endometrium becomes weak, it sheds. So if the entire proliferated endometrium is shedding, that means that will lead to a lot of bleeding. And that is why anovulatory cycles, they have excessive blood loss. They have heavy bleeding. Patient will say that her cycles are irregular. Sometimes they come in 2 months, sometimes in 3 months. They are painless and there is a lot of bleeding. Right? This is a characteristic of an ovulatory cycle. Right?